I come from Pakistan, and I welcome you all at some stage. I have no disclosures. The important thing from our perspective as surgeons, especially the young people who are starting out, to have some kind of a preoperative planning. So the basic is, first of all, make the correct diagnosis, choose the appropriate surgical approach, as it was just being discussed by Professor Massimiliani. Correct selection of patient, assessing comorbidities, looking at the DVT screen, other factors involved, anesthesia fitness, and then have a proper planning what exactly you're going to do in a particular patient. Anesthesia, very, very important that you need to have an experienced anesthetist, use minimal manipulation, video laryngoscopy if required, if you feel that the deformity is significant. And it's important that you keep the mean arterial pressure above 85 to make sure that you don't cause problems during positioning of the patient. Try to position patient yourself when you're doing these surgeries. Keep neck neutral during turning the patient. Have fluoroscopy ready just as you turn the patient so you can see and make sure that you have the appropriate position. Hyperflexion in this particular patient may be good for vision, but would be a wrong position. On the other hand, hyperextension in this patient, you've got poor vision, but that's probably a correct position that the way you want this patient reduced. On the other hand, neutral or mild hyperflexion may give you good vision and correct position. So you need to have this understanding of a deformity happening at CV junction. I think when you're positioning the patient, in order to ensure there are no complications, you have to have adequate padding of the knees, elbows. You protect the eyes. Temperature control has to be adequate. Mayfield, if at all possible, use that. TEDs, pneumatic boots, compression devices. Again, blood pressure, cannot underestimate that. And attachment of neuromonitoring should come into play at the same time. When you're going around operating on CV junction, you have to have adequate skin preparation and incision according to what you plan to do in a particular patient. Obviously, deepen the incision in the midline avascular plane in the midline rephi. Keep the blade perpendicular. Angle incision will cause shearing and very poor wound healing. In this area, posteriorly, because of you're taking away the blood supply of some of these tissues, has a high risk of infection compared to anterior, where there is risk is only 1 in 600. Dissection has to be careful on the periosteum. Do not penetrate the atlanto-occipital membrane. Be careful of the venous ooze, and usually respond to bipolar and Surgicel packing. Anytime you get a venous ooze, it's very simple. You've got patties, you've got Spongestan, Surgicel, whatever kind of hemostatic agent you have, and you need patience for a little bit of venous ooze that you're going to get when you're working in this area. Generally feel the C1 tubercle with the finger and then dissect. If it dips down and deeper to the C2 transverse process, do not go 1.5 centimeter lateral on C1 due to the risk of vertebral artery injury. And you need to see that beforehand on your preoperative imaging. Where exactly is the vertebral artery? Where is it going? And is it high riding? What about pars and pedicle? What are they like in this area? Wire fixation used to be done. In the past, we only use as an adjunct now. Once you've got screws in, to add some kind of bone graft in the back with the help of wire. Otherwise, this is not the way to go nowadays. We know it causes serious morbidity and mortality, and patients, because many times the bone itself will absorb if it's not a snug fit. Foramen magnum decompression may be required in some cases. Dural separation and feeding the wire penetrating the dural penetration should be done very carefully, and you don't want to be damaging the dura in this area. If you're going to be using wire, I think important to use the two-hand process, which is feeling and pulling the wire simultaneously. You cannot be having a wire pushing on the cord and causing serious neurological deficits in these patients. Occipital plate placement, midline screws, if you're going to be doing occipital cervical fixation, and that is now very rarely done. Majority of the cases, it's not required. Midline screws for maximum purchase because that's got the thickest area there, of up to 15 millimeter. Bicortical screws have double the pull-out strength. Occasionally, you can have a CSF leak or small venous, and it's very easy to put the screw on top of it to stop that causing you any trouble. So it's important to see that this is probably the best area to put in your screws and have your plate. C1 screws, obviously, if you're going to be doing C1 screws, expose the C1 lateral mass, which is deeper than the arch, so it's going down somewhere here. So what you do is you take a periosteum elevator and go right next to around the periosteum and dissect the venous ooze down. And you have some kind of a hemostatic agent with a patty, and you just dissect and leave that patty on that side, come on to the other side, repeat the same procedure, and you can always come back and put in a screw when the bleeding has stopped. It requires patience and periodic packing at some time. C1 screw, some people use smooth shank unthreaded screw thinking that it can cause irritation of the C2 nerve root. I don't do that and haven't found that to be a problem, but some people routinely do that and they've seen it. Adequate exposure of the entry point is important. You need to understand that when you're exposing, sometimes the artery could be coming medially over here and then turning its way, or you can have a very short entry or very straight artery. So you need to be careful where exactly the artery is. You need to see that beforehand before you do anything. C2 nerve root, as we just talked about, it exits right in front of you where you put the screw, so it just comes underneath that. So this is actually Goel screw that you're going to be putting in. So there are 3 different types of screws you can put in here. So every time you use this, you can use a bipolar and you can just push it down. If the C2 is coming in your way, you can bipolar it, tie it, and then section it. Do not let the screw impinge on the root as it can sometimes cause neuralgia. Do not go up to the anterior tubercle when you're putting in the screws, and the reason for that, and we'll show that to you shortly. And it's important that cortex should be just touched but not breach itself, because placement is manageable afterwards as well. So you make it easy for yourself by having a proud screw coming up. C2 screw could be pedicle, could be pars or transarticular. And you need to be careful about your entry points, your exits, and you need to study the images beforehand very carefully. With pedicle and pars, they're quite simple to do. You don't require much manipulation, and at the same time, if you've got decompression, you can put a hook and confirm that your screw is in the right area, not going medially as well. With transarticular screw, the important thing is to study about high riding vertebral artery and need to be careful that you catch both the sides of the joint with in an appropriate area as just Atul just pointed out. So internal carotid artery lying in front, you have to be careful when you're going there, and at the same time, where exactly you're going to put in the screws is important for us. So anterior relation of C1 lateral mass is important. So you've got hypoglossal nerve going in anterior to that. Carotid can sometimes come medially here as well. So all this is important. Both of these structures are important, otherwise you can cause problems to your patients. Isthmus sometimes could be really, really thin, and the pedicle diameter could be thinner than that. And once you do that, then you can injure the vertebral artery again. So you have to see that beforehand and how you're going to plan this. If you have image guidance, perfect. If you don't have it, you have to be careful how you're going to be putting screws. So planning is very important. The risk of vertebral artery with transarticular screw, in some series, it's up to 12%. Majority of the people have shown the incidence to be about 2%. And usually it's because of large tortuous, high riding artery and medially looping the artery. Sometimes it loops medially. Or if your transverse foramen is very wide and it can come medial and lateral and move around. Or if the pars is really hypoplastic and small, then all these can give rise to a problem putting in a transarticular screw. So for example, this patient here has, you can see a high riding vertebral artery, and you can cause this patient a problem if you're not prepared for it, and you don't go slightly lateral to your main trajectory. So you need to plan this beforehand to know where exactly you're going to be putting in your screw. And if you don't do that, you can cause a pseudoaneurysm like this, for which you'd require endovascular treatment. So management of vertebral artery, control the local hemorrhage. You want to make sure you don't cause any further injuries of thromboembolic phenomenon. There you do a tamponade with gel foam, Surgicel, bone wax. You use a combination of these. Not many people would do microvascular repair. You ligate the artery a level below. And then after that, you can send the patient for endovascular intervention if required. If it's happening during a screw insertion, fill the hole, tighten the screw. And the important thing is then do not put the same screw on the opposite side, because you don't want to be causing problem to the patient on the opposite side as well. Many people now feel it's safe to use a C2 translaminar screw. In our unit, we routinely use translaminar screws, so even the junior-most residents can put these screws. Very easy and simple to put in, as long as you've studied the lamina beforehand. And generally, the lamina, in about 90% of the times, would take these screws without any problem. You can even cross the joint with these screws, and works really well for us. So one screw goes in, the starting point is slightly anterior and inferior. The other screw, the starting point is slightly posterior and superior. And so you try that both of them do not collide. The translaminar screws are the easiest one. They have good strength, and that you don't even need imaging. The caution is sometimes rod placement could be nightmare. Obviously, the junior-most person is putting in the rod, so don't do this. You need to do this yourself to make sure that the reduction remains, and whatever good you have achieved stays as well afterwards. So you need to have appropriate decompression and fusion at the same time. So this is a bilateral translaminar screw shown here. Dural injury, you have to be cautious with it. You can use synthetic fascia. Nowadays, we use Tacoseal, which has dural substitute on one side and sealant on the other, and it takes 30 seconds to stop even any kind of a vascular injury as well. Obviously, CSF leak has high risk of meningitis, so you need to be careful. Infections is a major concern for all posterior surgeries in the spine. So generally, we use frequent irrigation with povidone, which is 2% onto the skin edges all along, and wash throughout. And because of that, we have found our infection rate to be really low. You need to avoid touching the instruments, touching the skin surfaces. When you immobilize these patients, it's important that you use Philadelphia collar or something like that. Then you need to have pressure sore. You can get because of the collar, because of your immobilization. So proper padding should be done, because if it's near your wound site, then you can have serious issues with your wound. So you need to identify the problem and sort it out. And so you can see a patient here, the occipital screws not put in the midline or on the sides, and poor screw purchase, and they would come out because there's a lot of pressure on these rods and on these screws. If you have a dysphagia following fusion, you don't want to have that because of too much of flexion done, and the neck is positioned in the neck, in the flex, too much of flexion. So you can easily see by flexing yourself and try to swallow, and you cannot swallow. So these patients get into serious trouble. So you need to fuse them in neutral position beforehand. Here you can see the screws used in the occiput, again, were too long, too thin. So ideally should be broad and should be short. And you need to drill them beforehand so that they work very well instead of fighting against it. So implant broken down because there's no fusion used here. And obviously in many patients with a lot of pressure, you can have problems. So you need to have a fusion planned as well for these patients. So if you're going to putting the screw anteriorly, the vessel could be there. And we talked about the hypoglossal nerve could be there. So you need to be careful where they're going. So do not aim for bicortical purchase unless you're sure, you're happy and experienced enough to do that. So I'm grateful. Thank you for having me here. And this is northern Pakistan, right next to the border of China, and hope to see you guys sometime over there.